All right, so I am going to turn it over to Chandra to introduce herself and let us know what they are working on over at the South Carolina Health Center Control Network. Thanks for being with us, Chandra. Over to you.
Thank you guys for having me. As they said, first off, good afternoon. I'm Chandra Beasley. I am the IT director and the program director of the South Carolina Health Center Control Network. So just a little bit about our network. We were formed in 2016 under the South Carolina Primary Healthcare Association. I want to take a few minutes also to just recognize any of my other HCCN colleagues that are in the room. And just take my hats off to everything that you guys do. I know you're doing a lot for your networks too, so I wanted to take a minute just to give you guys your roses too and to say hi. Um, so just a little bit more, going more into it. In South Carolina, we have a total of 25 member organizations that are currently under our primary care association. And of that, the HCCN member composite consists of 18 health centers and two lookalikes and a agriculture worker program that we run within the primary care association. Our network reach covers 39 of our 46 counties in the state. And we served last year 450,123 unique patients. So if we can go ahead and go to the next slide. So today I'm really excited to share how we're putting artificial intelligence into action across our network. What I'll share today is more than just a project. It's a part of our mission to empower our community health centers with technology that supports equitable and data-driven care. Um, in 2022, the HCCN, in partnership with Foresight Health Solutions, initiated an AI analytics pilot project. The pilot at the time involved two of our participating health centers. It was South Carolina at the time and Regenesis. The project aligned with two of our HCCN objectives for that year. And so our AI quality risk model uses advanced AI algorithms to analyze things that are clinical, financial, and operational data from across our participating health centers. So by bringing all of this data together, the system identifies patients who are at high risk for poor outcomes while also suggesting what the most effective intervention to improve their care should be. So if we're looking at it in short, it just really helps our health centers move from reactive to proactive. So instead of waiting for issues to surface, they now have the ability to anticipate them and intervene early, which in hand will improve both outcomes and efficiency. And so that's really the power of AI in healthcare. It's helping us to see patterns and opportunities that would otherwise remain hidden. Next slide, please. The quality risk model was developed specifically for South Carolina community health centers. Our objective at the time, and still is, it was very simple, to improve composite quality scores across all of our participating clinics that were participating in the pilot or in the project while reducing disparities in care. So how that works is the model looks at a variety of data points, things like missed appointments, chronic disease trends, lab results, and even non-medical drivers of health. And it quantifies each patient's future risk for poor quality outcomes. Once those risks are identified, the model then points us towards the most impactable actions, the outreach and care interventions most likely to make a difference. What's also exciting is that it shines a light on disparities across our populations, which allows our health centers to be able to design more equitable patient-centered strategies that help close the gap in care. So instead of guessing who needs help, They now have the ability to be in a know and can act strategically. Next slide. This initiative was made possible again through our collaboration with Foresight Health Solutions. Together, we designed and implemented the AI quality risk model. Um, we turned the data into truly actionable insights. The model doesn't just predict, it provides data-driven recommendations for each high-risk patient, which helps our providers deliver personalized care plans that are tailored to that individual's need. And we're already seeing results. First, we've seen a reduction in preventable emissions as care teams can now intervene before conditions escalate. Second, the model has been fully integrated into eClinicalWorks, which is the EHR system used by two of our health centers that are now part of this project. We are in the process of bringing on a third health center, which will be an Athena camp. And so we're excited about that and excited to see if we can get that same thing within Athena. Um, so what does integrating it into a clinical works mean, and how did we do that? So what we did was Foresight worked with eClinical Works to create an API that gave the ability as a link out. So it literally is um, um, up on the top of the page of the EHR to where they can click on it and it will link it out into the Caliper application. So this means that clinicians don't have to leave their workflow. And we all know clinicians do not like a lot of clicks. I don't either. So there it calms, it makes it seems very seamless and continued, and they have a great seamless workflow with that. They can also see AI driven insights right inside their existing system again. So finally, this model helps to optimize resource allocation. Staff time and attention can now be directed where it matters most, which is improving both the operational efficiency and patient outcomes. So this partnership has allowed the HCCN to take a major step forward in using AI to be able to support real world and data driven care. Next slide, please. So again, we currently have two health centers live on this project and one in queue. One of the health centers is Hope Health. Through this partnership, Hope Health has been able to use predictive analytics to identify patients who are most at risk for poor outcomes, particularly those managing chronic conditions like diabetes or hypertension. The care teams can now see risk indicators. They're able to prioritize outreach and measure improvements directly in eClinical Works. What's powerful about this approach is that it blends not only human compassion with, but also it's blending it with machine precision. So AI it's an example of how AI isn't replacing the clinical team, it's equipping them with better information, allowing them to provide more personalized, timely care. Hope Health's early success has definitely paved the way for other health centers in our network to adopt the same model, and we're looking at expansion of this impact across South Carolina. And what's also interesting about Hope Health is Hope Health was not in our initial cohort when we first started this project. So our initial cohort, we Hope Health was a little bit more advanced in their AI usage, and so we really wanted to initially start the pilot off with a smaller and bigger health center that really didn't have any experience with AI. One is still part of the project. Another one, when it came to doing setup, it was a little bit too much for them at the time. But now that we're about 4 or 5, well, now that we're a couple of years in, now everybody is wanting to get on board, even the ones, even the health center that had to jump off. But we after when this well next last I'm sorry last grant period, we talked to Hope Health, um, and we decided that we really did need to pull them in to be that mentor site, because of their ability to, and because of their knowledge of AI. They had been using Ambien and chatbots for a long time. So this was just that next level. And so that I'm very glad that we pulled them in. They are our champion site right now. So excited to see where we're going to go with that. So moving on into how Hope Health is utilizing it. Next slide, please. I'm sorry. Okay. Um, so let me start off by saying that clinical care alone doesn't explain all health outcomes, as we all know. Non-medical drivers, such as social and economic factors, can significantly influence cost and quality. So this slide shows how we identify those drivers and prioritize interventions. So here you see that we list major non-medical factors such as living alone, mental health issues, food insecurities, income issues, unemployment, transportation issues. And you see that for each we show a member count, which is how many patients are affected. We show the composite quality score, which is an aggregated measure of impact. And we also show the quality improvement potential, where targeted interventions could yield the most benefit. So these scores really do help focus resources where they matter most. So on the right, we see a consolidated list of contributors with member counts and how often these risks appear in progress notes. So for example, we can see that income issues, we see 2,173 patients and 806 noted in progress notes. Then if we look at unemployment, we see 1,983 patients, and we see 760 risks that were found in progress notes. And we see mental health issues at 1,027 members. We see transportation issues or transport issues at 588 patients, and 508, and all 588 were found in the progress notes. And so wanted to take a little bit of time to point that out, that we're not only looking, mining, prepare or mining the diagnosis codes. We're actually able to mine and get information from unstructured data that's found in the progress notes. Because if you think about it, especially health centers that are utilizing navigators and CHWs, they're out in the communities, they're doing community drive. Some of that information isn't going to be on within a visit, right? It's going to be in a note that was put in. When a patient calls and they're scheduling their appointments, and front office is putting in a telephone note, that's not going to necessarily be seen on that visit, right? It's going to be a note. So we're able to also get information of non-medical drivers by mining the notes. So these drivers often lead to missed appointments, medication non-adherence, and higher emergency utilization. So addressing them can reduce costs and improve outcomes. So for instance, if we're providing transportation support or food assistance, that could prevent avoidable hospitalizations. And so how are we using this data? Again, we're prioritizing the outreach for patients. Well, that's how they're using it. They're prioritizing the outreach for patients with multiple social risk. They're able to partner with community organizations for food, housing, and transportation support. And they're also able to embed screening and referral workflows into their care management process. So this is ultimately tackling those non-medical drivers. And that's key to improving, again, health equity and reducing the total cost of care. Next slide, please. Now let's take a look at how Hope Health is forecasting their patient costs. They are using a comprehensive risk scoring approach. That's what we're utilizing with this model that blends clinical and non-clinical factors to predict next year expenses at the patient level. So as you can see, um, the the Caliper Comprehensive Risk Score is generated by a machine learning model that looks across roughly about 130 variables. These include diagnostic groups that are derived from ICD codes, non-medical factors such as, again, transportation, housing status, food insecurity, just to name a few. We're looking at demographics like age and gender. We're looking at race and ethnicity groups, which we monitor carefully because we want to understand the equity implications. The model also integrates multiple dimensions to go beyond a single diagnosis view. The score tells us two practical things. It's the prediction of next year medical costs. So how much more expensive an individual is likely to be relative to their own baseline. It also does a comparison to the population average. So it's showing how a patient's predicted cost stacks up against our typical patient. So together, these help us. There is helping us in the project to be able to identify who may need intensive care management, proactive outreach, or benefit design review. And so I also wanted to take a little bit of time to kind of talk about our methodology anchor. So to ensure that we are clinically consistent, Caliper uses CMS's hierarchical condition categories. I knew I was going to mess that up, or what we call CMS HCC for grouping ICD codes. So HCCs help us to normalize comorbidities and severity into comparable risk categories so that we're not comparing apples to oranges. And so if we're with the scoring, we are able to forecast budgets and reserve planning with greater accuracy. We're seeing our participating health centers do that. They're also prioritizing, especially with what Hope Health is doing. They're also prioritizing care management for the highest risk members. They're closing gaps and optimizing medication management and coordinating specialty care. Um, they have the ability to evaluate equity. So, and we're doing that not only at a network level. I mean, they're not only doing it at their community net level, but we're also looking at that at a network level across all of our participating health centers and what that looks like across our network spectrum. Because we are looking to see and asking the question: are certain groups consistently predicted to be a higher risk, and are the interventions that are being done reducing those gaps? And we're also able to measure that impact. They're able to track whether interventions reduce the predicted cost trajectory over time. So, for example, if a patient's risk score suggests that the cost is 1.5 times the population average over the next year, they move into a high touch care pathway, care navigation. They also are looking at social support referrals and close follow up. And they'll monitor whether their score at actual cost trends down over the next 6 to 12 months. And so not only are they looking at that, but again, from their community level, that they are providing access to, we're also looking at that from a network level. So our next steps are to really be able to operationalize these scores within care management workflows and to align the performance metrics to reductions in risk and avoidable utilizations. Next slide. Here is a perfect example of those targeted interventions and services that I was talking about. And that ability to drill down to patient level to see patients with identified non-medical drivers. You can see the corresponding intervention to address this and on other non-medical drivers and quality screening needs. And this only gets better as we continue to use the caliper application, because the more that we're seeing that they're utilizing these targeted interventions, and that they're utilizing this for risk scoring, the more in depth the targeted interventions and services can get. And so we're and again, some of these interventions are not just being pulled from coding, from they're being pulled from what we're seeing is being done in the communities and what is being put in those notes that are non-structured data. Next slide, please. So where do we go from here? Our vision is to expand the quality risk model again across more of our HCCN members participating centers, and to continue refining it as we learn from real world results. I can say we have went through about 3 different iterations of our model. I don't believe in lock models when it comes to AI. Things are forever changing. And so you really need to be able to, spend a little time on data validation, on making sure that you're getting good data in, making sure that we're um, um, looking at risk and mitigation and things of that sort as we are continuing to optimize our model. So the path forward includes 4 major goals. The first being reducing preventable emissions by identifying risk earlier and responding faster. Um, you know, um, at CHI, for those that attended NAT CHI, and for those that have attended NAT Partner Conference, one of the things that HRSA has said and talked about as a change with the administration is really moving towards um, looking at the patient view, right? Making sure that we are kind of stepping away from just getting doing things to get the patient in and out, but really focusing on the patient as a whole and really empowering the patient. And so I think that our AI model and more that will come will definitely help to support those efforts to where we're able to do that. Um, Again, so that goes back to also enhancing the patient engagement through personalized outreach and education. Again, empowering our patients, making sure that that we are educating them and that we're doing what we can to empower them. Whether we're seeing transportation issues in a particular area, and we can go in, Hope Health can go in with mobile units, or whether it's a big transportation need. We've had one health center that's also part of this project. They actually, based off of what they were seeing, created a partnership with their local Department of Transportation, to put a bus line that runs throughout all of their locations. So being able to really do that non-traditional view of really helping the patient, and really getting the patient engagement, and empowering those patients. Again, improving health outcomes by really focusing on proactive and continuous care, and optimizing resource allocations to ensure that every dollar and every hour of clinical time delivers the greatest and possible impact. So ultimately, what we're seeing, and what our continued hope for AI is, that it's helping us to do what community health centers do best, and that's deliver compassionate and equitable care, but with even more precision, efficiency, and foresight. So we often say that AI, again, doesn't replace the human touch. It just amplifies it, by predicting risk and preventing complications and improving performance. The HCCN and its partners are transforming how we serve our communities. Next slide, please. So healthcare systems, we face mounting challenges. We're looking at rising costs. We're looking at workforce shortages, and growing complexity in patient needs. So safety net providers who serve vulnerable populations, our providers tend to feel this pressure even more. So AI powered solutions like our quality risk model help us tackle these challenges head on. They analyze vast amounts of data to predict risk and personalize care and streamline operation. And so in practice, when we're looking at personalized care, AI is identifying the patients, again, at higher risk, and suggesting the tailored interventions, as I showed with how Hope Health is utilizing it. We're, with operational efficiency, is helping to allocate resources where they'll have the greatest impact. Again, reducing waste and improving throughput, which is I'm Green Belt Lean Six Sigma certified, and that's one of the major things that you learn in doing Green Belt. Also, community well-being, by addressing risk early. We're trying to prevent avoidable hospitalizations, and improve overall health outcomes. Because as we all know, when it comes to hospitalizations, we get a lot of those patients on our panel from payers, and a lot of times, we're having to face kind of closing the loops with hospitals when if patients are going to the ED and getting that information. So this is taking it a step further, trying to create avoidance as much as possible, so that we don't even have to worry about closing that loop. Our patients are coming to see us. We're identifying their needs. We're being proactive and not reactive with the patient needs, and getting to them first. So, it's not about technology. That's not what it's just about. It's about transforming how we view and how we do care delivery. AI is and has given us the ability to shift from, again, a reactive to proactive care, which is essential for equity and sustainability. So as we adopt these tools, we're not just improving processes, we're also improving lives. And so with that, I will open it up for questions or comments. I'm open to feedback and comments.
Thank you, Chandra. I do see some questions in the chat. Maybe we can start with touching on some of these, and then if as folks are thinking about their questions, they can unmute at that point. Just want to say, loved like thinking about um, shifting our way of thinking about delivering care and using some of these tools to advocate, like at the community level and maybe even state level at some point. So just wanted to point that out. Um, I saw maybe like 2 to 3 questions related to collecting SDOH data. Can you just share a little bit more about the participating health centers and like how they're collecting that data, maybe even what tool or screening tool they're using?
So Hope Health, they're using different tools. So the main tool, so we're seeing usage of Prepare. Um, but if we're being honest, with Prepare, a lot of feedback that we get prepared for Prepare is that it's long. It's a lot of questions. Some say that the patients get irritated over time, and so we realize that. And so we know that although that is the workflow, they may not collect as much information as they would just reading off questions to the patient, which is why we were very intentional. And of course, we do codes. So, if there's any codes that are related to non-medical drivers, we're capturing that too. But again, we're capturing what's in a note. So we're using NLP to mine through the notes and look for patterns. So if a patient, and I think I gave this example previously. If a patient is calling to set up an appointment and front desk, and they tell front desk that that they're going to have to find a ride, and they're giving more information. Front desk is putting that in just a basic telephone note. Well, that's getting captured. And it's not attached to necessarily to a visit because the patient hasn't come in yet. They're actually creating their visit. Or another example would be CHWs, right? When the CHWs are going out into the communities and they're talking to the patients, and they're sharing, their able to the patients are sharing a little bit more because it's a more personal conversation. They're capturing that in a basic note that may not be, that community event would not be a visit for that patient, right? But they are capturing that in just a basic note and attaching it to the patient chart. So we're using NLP to again go through and mine that and search for that. So
Great.
those are the way. Those are just a few of the ways that we're seeing that things are being captured.
Great. Thanks for that response. I see a question also from Kevin about what kind of financial outlay is the individual health center responsible for to implement this tool within the EHR?
So the HCCN is covering this, which is why we only have 3 health centers currently in it. So we're covering this out of our budget, and we've covered this for this is our second iteration for awards. I will say that some of the consideration for AI for this award came out of what we decided. It was us. North Carolina was a early adapter, and Hawaii was also an earlier adapter with and they have their various models too. And so we're covering it out of our HCCN grant.
Thank you. There's another question here. Since you have implemented this, have you seen your rehospitalization rate within a month or so go down? And if so, by how much?
I don't have exact numbers for you, but absolutely. Absolutely. I wish I had pulled the numbers to share with you guys, especially for Hope Health. So Hope Health, we actually onboarded them fully in April. And since April, I want to say within in because they just presented on this at our annual conference, and I want to say that within the first 2 months they seen a 10% decrease, and so um, because they were able to get the patient in and really focus a little bit more heavily on outreach. Another thing that they did with it too is areas that they seen where the population, the work hours. That's another thing I didn't mention, but that's something I wanted to bring up too. Is where they had a population where it was a warehouse community, and so the work hours may be a little bit kind of misconstrued, and so that gave them the ability to open up access a little bit more, so longer hours in those areas. Also, Saturday clinics, things of that sort. They were able to find that again by utilizing things that they were seeing in the Caliper app to that could be possible risk. Because and access was one. That wasn't one that I shown on here, but access is a variable that we look at.
I see another question about just maybe confirming the understanding that the primary intervention for this project was that for people that are flagged as high risk, that the health center provides more direct outreach and care to those patients that are identified as high risk.
Yes.
Okay. And can you share more about what that looks like? And examples like the health center has more care managers, they're able to bill more and get reimbursed. What does that look like?
It just varies. It varies on what the plan is and what the intervention is. So I could give you one example of an intervention, not using Hope Health, but our other health center, Care South. So they were ones that I said they noticed quite a bit of transportation issues in various areas, and so based off of that and what they were seeing and what they saw too, they're not just looking at again the non-medical drivers. They're looking at they're able to compare it to different chronic diseases that they may be seeing that's trending. So they're looking at a variety of disparities across their communities, and they're able to really get down to not only city level but zip code level too, along with patient level. And so, based off of that, they actually started a mobile unit clinic where they hired a full-time nurse practitioner that is on the mobile unit. The mobile unit also has a CHW that rides on the mobile unit, and they also have um, MA that is dedicated to that medical unit, and they go out in the community and in some of those disparity areas where they're seeing transportation, and they're working with the outreach team for the outreach team to do the calls, get it set up, and then they're going out in the communities. The mobile unit is it was fitted with a hospital bed, is fitted with um, everything that you need to capture vitals. And so that's one opportunity that came out of again um, being able to address those interventions. And so transportation, and that was based off of intervention that they seen. Now, I do want to point out that the interventions that are provided are based off of interventions that they may have seen that they're pulling from various patient charts, right? So if they've worked with Find Help before, then it's looking at that to see, okay, well, this could be a possible intervention. So it's not like it's creating a new intervention. So I wanted to make sure that I wanted to say that it's not creating a new intervention. It's looking at past and trending interventions that may have been used, and then it's determining whether or not that could be a possible intervention for some things that are seeing going on.
Great. Yeah, thanks. That was a great example, Chandra. I did see a question about like what is the provider clinician perspective? Like how are they reacting to the use of this tool?
I've had two varying perspectives. So for Hope Health, their CMO is in love with this. He's working. They have a whole team that's based around this. Their whole quality clinical team, and then they also have a team of providers that are focused more on outreach and value-based care. So they love it because that's their focus and that's their area. Now, on the flip side of that, I do have the other health center that is participating. Their CMO, she's not as excited about it. For her, she's excited about it when it comes to like their CHW team. She thinks it'll be useful for that. She's excited about it when it comes to their school-based telehealth. Also, um, they are also the ones that I gave the example of with the where they have made a mobile unit team. So she thinks that it's good for that, but we're putting it in practical in everyday practice. She hasn't been able to kind of make that connection. So that's where I think I said at the beginning, we were very excited about bringing Hope Health. Hope Health actually came in after them. Care staff has been on this project for a while. They're seeing how the other health center is using it in practical care. Now she's coming on board a little bit more and understanding how it could be used in practical care too. So it really just depends on the provider. It depends on because if we're being honest, AI it could be a sticky thing for providers, right? Because um, you'll hear different opinions about it. It's taken away from bedside care, right? Or and things of that sort. So it's just really being able to educate them on how it's helping and how it's just an assistant and kind of leaning them towards that direction and offering them real world scenarios and real world examples and also offering them conversations, collaborative conversations that they can have with um, other health centers that are utilizing
Yeah, and like you're doing that right now in this space and sh sharing those real world examples so other folks can see themselves in it too. What is what does that kind of mentorship pairing look like? I'm curious with like more forward um, thinking organization. Maybe that's not a good way of putting it, but an organization that's jumping in full force and an organization that's maybe taking it a little bit more slow.
We took steps. We've learned from the past and other projects that we've done. You don't want to make it appear as if one health center is superior to another. So there are steps that you do it. So what we decided to do was actually bring in Hope Health to our conference and let them talk about overall what they're doing with AI, but with this particular project being like the highlight of what they're doing with AI. And so then they're able to take it, take it in as their own, like, oh God, this is great. I want to learn a little bit more about what they're doing with AI. So that was the first step. And the second step that we're taking is, so we have monthly calls that we have set up with Foresight, where we, discuss what's going good, what may be challenging. And we do that from a network level. They also meet with the health centers that are participating individually as just a training call if needed, or, just a feedback call monthly too. We are bringing both of those in together, and we're going to do a full call because that's where we know that, so that we're starting that at the beginning of the year, so that collaboration can happen, and so that we create a free space for the health center that may not be as advanced to ask the advanced health center questions, kind of creating that safe space to where they won't won't we're not putting them in a superior light. It's more collaborative. So that's how we've addressed that, and that's how we've been able to do that, and really um, kind of encourage that mentorship.
Okay. You're getting lots of kudos in the chat. I do see a question around um, cost, a ballpark approximate cost. I'll leave it to you whether or not that's something that you're willing to share. And also we have, an additional like 5 minutes or so. So if folks have questions, I invite you to unmute and continue to put this in the chat.
I won't give the exact cost. I will say it's not cheap, and I will say it's over 50,000 per year. So
Okay. I've got another question here. Um, Curious whether or to what extent partnerships with managed care plans, ACOs, or other value-based care frameworks um, would support this pilot or the potential for high-risk individuals.
So I will say, I know I mentioned that we're not the only state that's working with Foresight. Um, Hawaii is there. Like, they have their payers are actually the one that is fronting their partnership with Foresight. So it's possible. You know, we're not quite there yet in my state. There's discussions around it. We're at a point where we're trying to show the value of it so that in the future it can get supported. And so that's the approach that we're kind of taking with it. But it is being done. Hawaii is their payers are doing it. I think their payers, don't quote me on this, but I think if not all, a majority of the they're paying for a majority of their model. So
Great. Well, anyone else have any questions? We have Chandra with this wealth of experience. If anyone wants to unmute, we've got a few more minutes. You can squeeze in another question or so.
and it's why and I if anybody wants to reach out to them, why and I is the health is the organization that is doing it in Hawaii.
Great. I think I see someone unmute.
Yeah.
Sutaka?
Can I ask a question?
Yeah.
Wonderful presentation, Chandra. Appreciate the amount of work that must have gone into this to be able to boil it down to a few slides and give it to us so quickly. But I'm curious if the collection of SDOH data is really that easy, given that there must be so many user consent challenges coming through, and there is always the privacy risks associated with it. How do you all handle that? If you could share that, and then there's a second question if you have the time for it, I'll bring up.
Well, it goes back to validation and bias testing, right? That has to be done on a regular. I kind of mentioned that we've changed the model, some of the things in the model 3 times. And it came out of that. So, and part of that validation and bias from an HCCN standpoint is we have to be a part of that, right? We have to
Mm.
be a part of that because at the end of the day, the questions are gonna come to us, from the health centers. We're kind of the ones that are the intermediaries in between and kind of help facilitate some of those conversations and champion for our health centers. So we have to be abreast of what's going on. And then as far as liability and things of that sort, um, that goes with making sure that you have very detailed BAAs and MOAs in place. That is
Right.
and really getting and really making sure that you get legal involved, so to make sure you're covering everything and not only just doing it once but actually looking at it annually. With AI being so rapidly changing, you want to make sure that you can capture as much as possible, when it comes to security and liability.
Thank you. Can I ask a second one quickly?
Quickly.
Uh, was there a particular skew in the data for those with comorbidities versus those that were straight chronic, but no other behavioral issues, for instance, that sort of thing? Was that something that you were able to uncover? I'm trying to see if the risk factors were higher for certain groups. You sort of alluded to it. I'm trying to see if there is more data that we can parse into.
I will say this: it depends on the communities, right? I
Mm.
mean, it's not a straight laced answer for that. It just depends on the community. I'm in the South. They like pork in the South,
Yeah.
so we're going to we have and in different areas, they're known for different. I see somebody put pork fat rules. In different areas, they're known for different things. We have a big Gullah community, so they make their foods with pork fat and things of that sort. It's
Mhm.
tradition. And so we do have high diabetic numbers. We do see higher hypertension. We have a lot of rural areas, right? So in those rural areas, we might see transportation needs. We see in some of those rural areas, we'll see high unemployment rates. It just kind of really depends on the area. But I will say that it I, I'm not from South Carolina. I've been in South Carolina. I feel like I am now because I've been here so long. I've been here 11 years, but
Mhm.
it really has helped me to know the communities a little bit better just by looking at the data trends. Because I'm able to look at some of those trends, and provide you with the information I'm telling you. Like, I know that if I'm looking at um, one of the areas, I'm like, okay, um, that area is. I think I gave the example of, like, where the warehouses are, right? And
Mhm. Mhm.
the hours are high, the hours are long, and so then we got to look at access, right? So it's making me kind of be more aware of the communities and stuff that are in South Carolina too. So yeah, I mean, it just kind of depends, but you- that's where you got to let the data tell the story.
Yeah, that's where the AI can help too.
Yeah,
Thank you.
absolutely.
Yeah.
Absolutely.
Thank you so much. Appreciate it.
Thanks
Thank
for
you.
the question. Yeah, thanks for coming off mute. All right, we've got a few minutes left. I just want to thank you, Chandra, for joining us. You've been such an excellent partner. Just like Sujata was saying, like really put this together in a few slides, but just very clearly. So that was excellent. Thank you. I'm going to pass it over to Wes to close us out. Thank you so much again, Chandra.